Welcome to the channel and welcome to the Abcde Assessment Practical Skill Guide. We'll walk through this patient assessment tool and touch on the rationale behind each step. The Abcde assessment is taught pretty widely amongst the multidisciplinary team. It's one of the advantages of the model, and the principles do stay exactly the same, but there are different focuses depending on your role, and this guide is from a nursing perspective. Abcde is a mnemonic, which stands for airway, breathing, circulation, disability, and exposure. To use this tool properly, and therefore effectively, the assessment needs to be carried out in the alphabetical order. This is because the focus of assessment starts with the most urgent and life-threatening, and then the next most urgent, and so on. Any acute needs identified need to be dealt with before moving on to the next step. A is for airway. You want your airway to be patent. An airway can be partially obstructed or fully obstructed. An unpatent airway is basically a countdown to cardiac arrest, so any obstruction in the airway is a medical emergency. A quick, effective way to check airway patency is to ask the patient a question. If they are able to respond in a normal voice with ease, at least relative to what's normal for them, the airway is open. Coughing, audible gasping for air, and choking, if you ask them a question and they're struggling to produce a vocal response, indicate a partially obstructed airway. They might be in too much respiratory distress to give any kind of response, but you'll hear wheezing, rasping, and other respiratory sounds as air tries to flow through the smaller space in the airway. If there is no sound from the airway at all, the airway is fully obstructed. There is no chance you're going to get a vocal response. Despite the lack of noise, especially if they're conscious, you will see a lot of distress and a huge visible effort to respire, but no respiration is happening. If the airway is obstructed, it requires intervention. Firstly, think about your basic life-saving. If someone's choking and it's noisy, so it's a partially obstructed airway, you want to encourage them to cough, encourage them to clear their airway. If you can't hear any sound from the airway, it seems fully obstructed, you give 5 back slaps and 5 abdominal thrusts, which is the maneuver formerly known as the Heimlich, alternately. So 5 back slaps, 5 abdominal thrusts, 5 back slaps, 5 abdominal thrusts, until the airway is clear. If the patient's unconscious or you need to otherwise open up the airway, you have the head tilt chin lift maneuver. Only attempt to remove visible obstructions. Don't go poking down the airway. You're likely to push the obstruction down further, or irritate the airway, or damage it. Just don't do it. If it's a liquid obstruction like vomit, bleed, or sputum, you can try repositioning the patient so that it drains out of their mouth. The recovery position's great for this. And if you have the equipment, you can try suctioning. Again, unless you're providing specialist care, only suction what you can see. Don't try and push your Yankee down the airway. If you're worried about the patient's ability to maintain their airway, you may need to consider inserting an oropharyngeal or a nasopharyngeal airway, and you might have to intubate in the worst cases. Only once you've sorted out a patent airway should you move on to B. B is for breathing. Satisfactory breathing is when your patient is receiving sufficient oxygenation from an acceptable level of ventilation. Now for your standard patient, this is going to be oxygen saturation over 96% on room air and them managing their own ventilation, but your patients will have their own acute and chronic baselines and targets. For example, a COPD patient is only going to be aiming between 88 and 92% oxygen saturation and may only expect it to be achieving these with supplementary oxygen. If your patient isn't getting sufficient oxygenation from their breathing, they're going to be hypoxic. Their cells, tissues, and organs won't be receiving the required amount of oxygen. And for oxygenation to happen, the action of bringing air into and out of the lungs, ventilation, also needs to be working properly. This can be impaired by reduced lung inflation, bronchospasm, pain, reduced respiratory drive from opiates. These can all limit ventilation and prevent an adequate amount of oxygenation. So what we look at when we're trying to ensure oxygenation and ventilation is respiratory rate, the rhythm of breaths, and the depth of breaths. We monitor oxygen saturation, check for synchronizing bilateral chest movements to indicate how the lungs are inflating. Cyanosis is a big telltale sign of hypoxia. The sound of a patient breathing tells us a lot about the way the air is moving in and out of the lungs. And if you've got a stethoscope to hand, auscultating will give you a great comprehensive picture of what's going on with your patient's lungs. So you're looking and you're listening to the breathing, and actually placing your hand on the patient's chest can make identifying each breath clearer if you have a patient where it's difficult. When we're assessing breathing, don't forget any chest drains, supplementary oxygen, or mechanical ventilation devices which are helping the patient to sufficiently breathe. Check that they're working, check that they're at an appropriate level, check if they're needed. To get your patient's breathing to a sufficient level, it may be as simple as repositioning the patient to help them with their ventilation, supplementary oxygen therapy, boost oxygenation. They may be prescribed nebulizers. They may require mechanical ventilation. C is for circulation. What we're looking to ensure here is adequate perfusion of the tissue. Once you've made sure the blood is oxygenated, we need to make sure it's getting around the body to where it's needed. Inadequate perfusion starves tissue of oxygen, which unchecked leads to organ failure, even death. Assessments under circulation are also primary indicators of sepsis or major bleed. We look at temperature, typically as an indicator of infection and also because it's going to be affecting your blood vessels. Obviously, core temperature is important, checking for cold peripheries, test of peripheral perfusion. We monitor heart rate and rhythm. A slowed rate is itself a risk to perfusion. An increased heart rate is often to compensate for a drop in perfusion. Make sure also to note the rhythm. We measure blood pressure. Obviously, hypertension is a worry, but hypotension in particular is a sign of poor perfusion and a systemic failure to deal with it. Hypotension is one of the key indicators of sepsis and can indicate a big old bleed that the body just isn't able to deal with. Capillary refill time is a really good, more precise measure of peripheral perfusion, and monitoring urine output is a great indicator of whether or not someone's got enough fluid in their body, even if now the body's compensating for it. Any kind of fluid output, be it vomit or the volume coming into a drain, is going to affect volemia and therefore circulation. So bear that in mind when you're calculating your fluid balance. Make sure you check your drains, your catheters, your cannulas and other lines, which are all going to be players in your patient's circulation. Your circulation-related interventions could be anything from just repositioning and popping your patient back in bed, encouraging oral fluids. You might need IV fluids. You might also need to use medications, particularly if you need to dramatically intervene with a heart rate. And obviously with certain arrhythmias, you might have to shock the rhythm. If you've got circulation concerns, you're going to want to make sure you're closely monitoring the effect of your interventions. And particularly with cardiac, you might want to pop them on a continuous monitor. It's a good idea to also get a 12-lead ECG. If you've escalated, you're going to get asked for one anyway, so you might as well take one now and have a look at it too. D is for disability. Under disability, you're assessing your patient's level of consciousness. Obviously, you want your patient to be alert and fully responsive, but if that's not their baseline, then you want their level of consciousness to be stable, with no signs of deterioration. Depending on what's appropriate for your patient, you might be using the avpu scale, which measures response from alert, verbal response, pain response, unresponsive. Do make a note of new confusion as well, or the Glasgow Coma scale if you need to be a bit more precise, and this gives a score for each kind of response that it measures. And you do get other measures of neuroresponse, but these two are very common. Attached to level of consciousness, consider checking blood glucose, particularly if the patient is at chronic or acute risk, and have a look at their pain level at this point as well. Pain's a really important measure of acute health, as well as being part of a patient's holistic well-being. Also have a look at any sedation that they're on, and if there's any chance that it might be affecting your patients. If you can identify a problem like glycemia or oversedation that can be treated with glucose or insulin or naloxone, then great. But a lot of your focus with a drop in level of consciousness will be stabilizing your patient and then identifying what's going on, especially ensuring that the airway stays open. Finally, E is for exposure. Now this is an instruction. You fully expose the patient and assess them from head to toe, making sure, of course, that you're respecting the patient's dignity and also making sure that they don't lose too much heat. You're looking for any signs of trauma, bleeds, bruises, rashes, etc. Remember known wounds that you may be treating and may be dressed, and use touch to check for tenderness, temperature, to feel swelling and edema, etc. And check points at risk of pressure ulcers. So by this point, you've got a pretty comprehensive assessment of your patient. Do remember to stick to the order and also to intervene when needed at each level before you move on to the next letter. For a video looking at the principles, pros and cons of this assessment model with a quicker overview of the steps, check out Abcde Assessment in Short. Thanks for watching. I hope you found this video useful. Give us a like if you enjoyed yourself and subscribe for more nursing videos. Bye!